Good morning, everyone. Thank you for joining us today for another CU Anschutz School of Medicine Town Hall. In our previous town halls, I've asked school leaders in new or enhanced roles to join us to share our common vision. However, in response to your feedback, wanting to hear more from our hospital partners, today I've invited Dr. Tom Gronow, yes, Dr. Tom Gronow, who has a Doctor of Education, and is also the President and CEO of the University of Colorado Hospital, to join me today. Welcome, Tom.
Thank
you for doing this. Our conversation today will focus on an important driver of our shared success: the partnership between the School of Medicine and the University of Colorado Hospital. The strength of our clinical, research, and educational missions really depends on us working together on clearly aligned goals and building structures that allow the school and the hospital to work well together. Funds flow is one part of that. And funds flow is not just a financial framework. It's the way we really translate our shared priorities into a model that is fair, sustainable, and designed to help all of our faculty thrive. Today, we'll walk through the principles behind that model and answer questions that many of you have raised. Remember, though, that this current funds flow arrangement only applies to UC Health and only to this campus, although we hope to expand that model further to our other hospital partners potentially and beyond this campus, hopefully. Funds flow can be a very complex topic, so today Tom and I will walk through the intent, clear up some misconceptions, and talk very openly about where we're heading as a campus. Tom?
Thanks, John. Glad to be here today. I think the exciting part of this conversation is where we're heading, most importantly, together. Sure. That alignment is really critical, but having a sustained and equitable approach to us getting to that destination was a key foundational step, I think, for you and I as you joined a little over a year ago. We've spent a lot of time on this, a lot of long conversations about this, and I think today we want to cover what's changing, what's not changing, how does funds flow position us for success,
right,
and how does it help us achieve our aligned vision of being top 10 in 10. We want to get there sooner than that, potentially, but this is the foundation, I think, to help us get there, to reduce the friction and clear the path for us to focus on the key things that are going to help us achieve that.
Yeah, Don always says, the Chancellor always says top 5 and 5, which I think is perhaps a stretch goal, but we're going to stretch to try to get there, and this
Absolutely.
is a big foundational step. And while the approach to funds flow has taken some time, I think we've actually been able to do it in record time, and I appreciate that partnership. Let's start with a misconception. Some people have said that we used to get support from UC Health for department overhead or a department tax. And tax is not a great word, but it's just that money that we use for some of our other missions. And I want to be perfectly clear that that's not accurate. It's not accurate that that's been taken away.
Sure.
The dollars associated with supporting department operations, shared infrastructure, and administrative support still exist. Funds flow is just a formulaic way that we calculate the support necessary to pay our faculty when their collections from their work is insufficient to do that. In the past, a fixed dollar amount might have been negotiated between a department and you or UC Health more broadly, but there was no guarantee that that number would continue from year to year, that it was sustainable. But now the support needed is calculated. It's formulaic and reduces that friction. But the overall amount is the same, and frankly, even a little bit more this year than we got last year. So if department overhead or tax was included previously, or if money that was used in that relationship was available for those things or for other missions, that's still the same. It's the same now as it was then. It just comes in a different form.
Right.
You know, an analogy that I like to use, and I'm becoming, I was going to say famous, but probably infamous for analogies, is something like if you went out for dinner. So if you went out for dinner in the previous model, you might have received $80 for the meal and $20 for the tip. And if you consider the meal part, the $80 faculty salary, and the tip, overhead or tax, in the new model, you simply get $100.
Right.
So it's like a fixed tip. But it's basically the same $100, just packaged a little differently.
Yeah. I mean, financially speaking, nothing has changed from what you've said. The dollars that are flowing over in aggregate for clinical funds flow are more than they were last year. I think the pieces that we wanted to define are more of these categories of the types of work, and we'll delve into that a little bit more in this conversation. But there's a number of things that we have to consider in the equation. And how this started was essentially a book of deals. You and I have referenced this book of deals many times. And it was the series of 18 different clinical departments coming to have 18 different negotiations. If it's divisions, if it's other folks that are coming to say, hey, I've got this idea. It's usually where it started.
Yeah.
And some ideas were great. We're saying, great, we're in. Let's figure out how to do this. But it's that predictability and sustainability that we didn't ever solve for.
Right.
So it became a year after year after year conversation to say, well, this is working well, but I still need support. And my question was always, well, how do I know you need support?
Right.
So the whole goal here is just to reduce the number of questions, to get to transparency, to say, here's the base set of data that we're going to work from to make decisions. And that gets into clinical departmental revenues, it gets into productivity, it gets into needed staffing models to cover our coverage services, but we work together and we use benchmarks. I think that's the other piece that's really different. And those benchmarks just quell the conversation. It gets us away from, but I'm different, I'm special, because we're benchmarking against other academic medical centers.
Right.
So it helps create a more objective conversation so we can make the right decisions as to where we want to head.
Yeah, I would say you could say it's objective. You could also say it's fair, right? Or even more than fair. I mean, what we're able to do now is allow that to be sort of one negotiation, and then we'll put that into a form that's understandable and predictable that everybody agrees to. What I didn't like about the Book of Deals is it put you and maybe me or you in the chairs in sort of a constant state of negotiation. And while I think those negotiations have gone well, when you're always negotiating with someone, it creates a different relationship than when you have an understanding overall of how things are going to work. That doesn't mean there can't be exceptions, and there will be, but that Book of Deals now will be much clearer, and it'll be much more straightforward with funds flow than having this book that we have to look back at where there maybe have been misunderstandings.
And it distracts us from
Yeah,
being able to
from
focus
doing the real
externally
work.
and do the real work. Exactly.
I agree. So I wanted to address another question that has been on many people's minds, and we've heard this when we've gone around to the departments, and that is, what does funds flow mean for my pay, my compensation? So let me be clear again, funds flow does not change compensation, nor does it change your compensation plan. It's very important to me that departments and their leadership will still determine your compensation. I should note as an aside, and we've talked about this, that we are going to embark on a process to reevaluate our compensation plans. But that's really not tied to funds flow. Rather, it's my goal to develop compensation plans that allow our faculty to directly predict what they'll get paid. I want our faculty to know that if they do extra work, they will get extra pay. And I want this to be true across all of our missions. And that's not always true today, and I think that's wrong. So while we're going to embark on that, it really has nothing to do with funds flow. Can I ask you, Tom, to talk a little bit about how you see funds flow supporting compensation and that aspect of things?
Yeah, I think a lot of this goes back to where we had lack of transparency. And the intent, and I want to make sure this is clear, I have zero desire to control compensation plans, nor do I want to get involved in compensation plans, because as you said, that just creates more work, more conversations, more distractions.
What's the purview of the chairs and the leadership
Exactly.
in the departments?
Yeah, so, and that's key that we maintain that
Right.
through this model. We've discussed that as a key component. So you have your clinical, administrative, educational, and research components. And the dollars that were flowing through previously were often going to cross-subsidize some of that work in different missions. So we have to get
And that
clear.
wasn't transparent.
Correct.
Right.
So it was really at the purview of the department leadership to say, how are we going to use the dollars that we've negotiated with the hospital? And I'm not slighted by that. I don't feel angry that we were not clear about that, because we're investing in the mission. All
Right.
three missions are really critical for us. But when you look at how we get to the simplicity of a clinical funds flow model, we're really trying to isolate the work that truly is a clinical FTE. And I know the schools embarked on work externally with Chartis
Right.
to work through those calculations. But that does start to put us into a conversation around how do we define CFTE, how do we use RVUs, how do we use benchmarks, how do we use sessions or coverage hours to determine where we are in a benchmark
Right.
and on the continuum. So if somebody is a 0.6 clinical FTE, and the balance of that is administrative or research or teaching, then we need to focus in on that 0.6 FTE and set the transparency and clear expectations around what we're looking for. So the easy example is if somebody is expected to produce 5,000 RVUs at a 1.0 clinical FTE, then we'd expect them to produce 3,000 RVUs at a 0.6 clinical FTE if we do that math. And that just lowers the temperature, and we're normalizing for what the clinical effort is, but we also had to step back and say, well, where do we define, or how do we define that clinical effort to begin with? So we wanted to define something that was more than fair, and you and I spent a lot of time talking about benchmarks. I know you have some opinions on this as well, but where we landed was parity around compensation and productivity to, again, lower that temperature and have something that is more than fair when we're seeing different trends across the U.S.
Right. And we'll get into a little bit of that concept of more than fair with one of the questions that we received online. But I think the key part for me here is that while we've had a more of a focus on what people are doing in all of our missions and what is a fair compensation for that, from my perspective, if we don't have that, then we can't reward people for doing that extra work, be it clinical, research, or education. And funds flow really allows us to define that so that we can fairly reward people doing the work for all their different missions. So I think that we need to sort of move ahead maybe to another question that we have online. Our model is more than fair, and we talked about that a little bit. At other institutions, what typically happens is that there's this concept of I call it an academic gap or a gap. At those institutions, and this is true really across the nation, faculty are expected to work clinically, let's say, at the 65th percentile for pay at the 50th percentile. In fact, this was the model that had been developed at Duke. That gap really reflects the reality that the clinical mission often does have to subsidize other missions because there's cap and pay for other missions. For example, the NIH cap is around $200,000, and many of our faculty would get paid more than that. And so there has to be a difference here. What we decided to do when you say parity is that funds will come over to pay people at parity, meaning if they're working at the 65th percentile, there will be sufficient money coming to the department, including their collections, to pay them at that level. The idea here is that the compensation and the compensation plan are still the purview of the department, but there's enough money coming across to support at parity, which from what we've been told from our consultants really doesn't exist at any other institution right now.
That's right, and I think you and I had some time to spend with colleagues nationally a few months ago, and through one of our academic medical center cohorts, funds flow was a 3-hour topic because everybody's dealing with this.
Right.
And even if they've dealt with it, they're still revisiting a lot of these conversations because they're trying to find the right balance with a changing external dynamic.
Well, that's true too, right? We're seeing a lot of threats.
Yeah, we're seeing a lot of threats, and we don't want to be schizophrenic and constantly change the model every single year.
Yeah.
That's the other piece from a predictability standpoint. If we align our funds flow models and, as you talked about, have compensation models that justly reward people depending on how they're producing, what they're doing, what type of work, complexity, and we know that not all models that are driven off benchmark are perfect because we are an AMC.
Yeah.
We do things that are more complex. We do things that are lower RVU generating if we have a niche program. But we can have conversations about growing those programs versus arguing over why did John get this and Tom got that. It doesn't matter.
Well, and in fact, we have a committee that's set up, and if there are questions or things that come up, maybe a benchmark's not appropriate, or maybe we have to escalate that benchmark because market forces are pushing us in a certain direction, then we have an opportunity for faculty or chairs to present that to the committee. And we've actually done several of those already. We've approved some of those.
Well, the other key piece, too, is when we talk about the parity piece between productivity and compensation, and this really plays into the first year of this model. Everyone knows this is a new model.
Right.
There's uncertainty. How is this going to perform? What does this mean for me? That's why we're having this conversation today, to address some of that. But the upside that we wanted to provide in the first fiscal year, this fiscal year, is that if you outperform the budgeted model, instead of us saying, well, that's nice, now you can pay the hospital back for the
Right.
dollars that you had.
Right.
You keep those dollars as an incentive to start thinking about how does this model get applied to me, to the department, so that we can be more productive and perform well together. The whole goal here is not to take money away from the academic mission, the departments, the school. The goal here is all boats should rise
Right.
because of this. If we're aligned on the economic models, if we're aligned on the incentives, if we have clear plans about where we want to head, then that takes the guesswork out of what does it mean for me, what does it mean for the department, and if we're performing well and growing together, then we all should be successful,
Right.
which means we can continue to reinvest in our key missions.
And we'll come back to some of those issues because some of the questions we got ahead of time,
Yeah.
we'll probably address those. But I also think what's really important as we've done the effort work is to go ahead and figure out what drives people, what are they passionate about, so that they can do the work across our missions that they're passionate about and can get fairly rewarded across those missions. Whereas before we really didn't have any sense of how that was working and what people were most passionate about. I found that benchmarking brought up a number of additional questions. For example, how do expectations of shifts and hours work? But what if someone works nights or weekends? And are there shift differentials that are built in? And in fact, shift differentials are actually averaged into the benchmarks. But those expectations, to be clear, can still be managed by the department so that they can create compensation differentials that are best for their faculty. So for example, let's assume that a group of hospitalists respond to a benchmarking survey on the hours that they work. And that's how these benchmarks are created. There's surveys that are done locally or around the nation. And let's say that half of those hospitalists work only nights and weekends. And so they might report, and I'm making up numbers here, but they might report 1,600 hours a year. Conversely, because daytime work is perceived by the department as easier, those hospitalists that work strictly during the day may be asked to work 2,000 hours annually. But when the survey results come out, the average is going to be around 1,800. Mm-hmm. So that's really how we've worked on funds flow. We've created a funds flow to support that average of 1,800 hours of work. Again, just an example of making up numbers. But then the department can redistribute that support across the shifts as they believe best supports their faculty.
Yeah, I think this is a key piece. That the benchmarks, we're assuming apples to apples. We're using the AAMC or CPSC benchmarks, which
Right.
compares us against other academic medical centers. And they're dealing with the same issues we're dealing with.
Right.
So that we wanted to pick the right benchmark. We also wanted to ensure that we have simplicity. And as
Right.
you mentioned, we've developed committees to be able to look at this. If we've made a poor decision, if we've chosen the wrong benchmark, if there's better data out there, then we wanted a process to be able to listen so
Yeah.
that we can at least understand what's the argument, what's the case, and does it make sense. What we're still trying to get to, I think from a guiding principle, we talked about transparency, we've talked about more than fair. Simplicity is a real key piece.
Right.
Because we could easily overcomplicate this.
Well, that makes it predictable too, right?
That's
If
right.
it's simple,
Yeah.
it's predictable. And I should say that the decisions we've made in that committee and in other aspects of funds flow have always been done by a committee that had equal representation from the hospital and from the school and involved chairs and DFAs. So I feel that when we had those discussions that we got to a point that was pretty fair for everybody, and we
Yeah.
made those decisions as a group. And in fact, sometimes we have escalated compensation beyond benchmark because we felt that was necessary to be, effective in our market. And we've also changed things as we've gone along. So it doesn't have to be a static model, but most of the things that are in place allow us to make some dynamic changes, whereas before we were sort of mired in this quagmire of everything was a discussion.
Yeah.
So another question that came up, which I thought was actually quite interesting, is one on PTO. And the question really was, how does PTO work into this? And do I have to make up that work? So if I take a week off, then do I have to work twice as much the next week in order to make that up? And I found it interesting because the truth is that PTO is really baked into these benchmarks. And so they still allow for everyone to take their PTO and take their vacation time. More specifically, we received a few questions regarding, literally, do I have to do an extra clinic for 6 months if I took a week off? And so if the question really is, does funds flow require you to make up clinical work that you didn't do while you're on PTO, the answer is just no. And if you think about it, benchmarks include and represent averages. And so across the country, people are taking PTO and they're not working during that time. So those benchmarks actually include all of that. And that doesn't mean that we're going to take away PTO or make you work more when you return. Fair?
Yeah, it's fair. I think if we were summarizing what the benchmarks comprise, it comprises total cash compensation, which reflects PTO. It accounts for shift differentials that we've talked about because we're looking at the aggregate across the board. We're trying to be consistent with national standards so that
Right.
we're not creating custom benchmarks, we're not inventing benchmarks or saying this is just
Well, that's fair on
how we
both
do it.
sides, right?
That's right.
That way we can both have a sort of an equal arbiter, if you will.
That's right, and they're nationally updated. We can update them year over year, so we know
Yep.
what's changing in the market. They account for shifts in RVU values, CPT code changes. All
Correct.
those things are accounted for in these benchmarks.
Yeah. So we've covered a lot of specifics as far as numbers and how support will be calculated. But I think we'd be remiss not to explain two major models that we've used in funds flow, coverage and structural.
Sure.
Can you explain those to the audience?
Yeah, happy to do so. So we live this every day, so
Right.
we just rattle it off and expect that everyone understands exactly what we're talking about when we say that these models are pretty standard, and they are. So coverage models, you think about the work that puts you into a coverage model category. I think the biggest differentiator is you are a volume acceptor, and irrespective of the volume that's coming in or not coming in,
You don't control it.
you don't control it,
Yeah.
right? So you are covering an intensive care unit. You're covering a shift for call, for a consult service,
Right.
or you're looking at examples where if I had 50 patients or I had 5 patients, there's a core staffing that still has to be there to take care
Right.
of those
You
patients.
show up to take call and you never get called.
That's right.
Or you're in the intensive care unit and it's empty. Or it's a light OR day, things like that.
That's right.
So the physician's unable to bill, and therefore their collections will go down. So that's a type of a coverage model.
And the key piece between both models that I think is important to recognize is that everything is still net of collections in both
Yeah.
models, right? So if you do minimal work versus you're doing a lot of work, the collection offset is still applying. But what we're doing to reduce the concern or the fear around, am I going to be able to cover my salary, or
Right.
am I going to get the right support to be able to be paid appropriately? You really have to look at benchmarks, and we have to agree on what the base coverage model is.
Right.
So if you're using advanced practice providers, you're using physicians, you're using residents, fellows, we have to account for all of that within the model to say, here's the required physician, CFTE, here's the required advanced practice provider, CFTE. We load that in the model, we use a benchmark salary, that creates the funds flow, and then that's offset with the collections to create the net support amount. So that's coverage.
Yeah, so in coverage, it's basically you can't control the volume.
That's right.
And then structural?
Structural is more where you have a defined volume, or you're working.
You have a clinic template.
Clinic
and-
template, you have referrals that are coming in, you're getting those scheduled, and you're working
Right.
through a process. So from a structural standpoint, looks similar, but we're basically setting targets around the work. So we're
Right.
using WRVU benchmarks. We're understanding how many sessions that you're in clinic, defining the CFTE. We're looking at the benchmark and multiplying a predicted amount of support that you would need from a salary perspective.
Right.
We net that against the actual collections, and then that determines the flow that's coming, or the funds flow that's coming. So I
Yeah.
think what's really important in this is that there are considerations for collections.
Yep.
There's considerations for payer mix. And those are things at a high level we want to ensure that we're watching from a business perspective.
Right.
Because we need to have a sustainable model overall
Yeah.
on the campus. So there needs to be not just a reward for doing more. If you're doing more, producing more above a benchmark, we need to make sure that we're growing in the right areas
Right.
to sustain
Priorities,
the ability to do this.
Right? To make us top 10 and 10 in some of those
Exactly.
areas at least,
That's
right?
right.
So Tom, another area where I believe funds flow is beneficial to the departments is this sort of baked-in recruitment support,
Sure.
if you will. So paying a new faculty member full salary, which they expect from day one, while they're ramping up their practice, has been an issue in the past, and the departments were really liable for that cost. As an example, a new hire starts on July 1. And it's expected that they would, to make their compensation, they would fill their OR room, for example, on day one. But that's not going to happen.
Right.
I mean, that surgeon, she hasn't gone to clinic yet. She can't fill her OR room, so that her RVU targets would be hard to meet. in that first year. And in our previous model, that gap between what they could collect, because the OR takes time to fill up, and how they were paid, there was a gap there that oftentimes would fall to the department. How does it work now?
Yeah, one thing that we built in for the funds flow model beyond the first year, this fiscal year 26 that we're working in, is when we look at the recruitment side of things, we're still using a benchmark,
Right.
still starting from that point. But what we're changing in the first and second years is the ramp up expectation.
Right.
So in year one for a new recruit, we have expectation that you're going to be at 60% of benchmark. In year two, you're at 80% of benchmark. We're including recruitment costs into there
Right.
that we previously have not included. And what we've said is if you beat the expectations in year one,
So good
and year
management
two,
by the department?
yeah, good management by the
Or
department.
fix access problems, things like
Somebody
that?
who's motivated, who wants to get
Yeah.
in and hit the ground running, and they don't have as much of a ramp up period, then the outperformance of that is retained within the department, which can be invested in other
Right.
missions.
Yeah.
So that is really important, and we're still using a formulaic and clear approach to determine what that recruitment
Right.
support is going to look
Right.
like. So again, predictable.
Yeah. So in my last town hall, we talked a great deal about collaboration between departments, and I see us benefiting from funds flow across all departments. And to that point, we did get a thoughtful question from a doctor in primary care, Dr. Dan Matlock, who's an associate professor in the Department of Medicine. And he asked, he says primary care is not lucrative for a hospital system. You may disagree with that in a way, but serves as the front lines of medicine, which I think they do. And many systems actually subsidize primary care clinicians for the services they perform for this sort of so-called downstream referrals or downstream revenue. Can you explain how you've thought about assuring sustainability among primary care as you've developed funds flow model? That was his question. And so first of all, Dan, thanks for the question. I appreciate the engagement. And I'm happy to start. UC Health has in fact traditionally provided support directly to our primary care clinicians as part of our affiliation agreements. And I want to be clear that that remains untouched, and that's above and beyond funds flow.
Correct.
So primary care physicians also, I would say from my perspective, also engage in more true hands-on teaching. Particularly of our medical students, for example. As a neurosurgeon, I would be unable to teach a medical student how to use a stethoscope, for example. But this is time away from their productivity. So aside from the clinical funds flow, from my perspective, when we get to educational funds flow, this is where there'll be a distribution of dollars from the School of Medicine to make it appropriate and to offset that productivity lost in primary care.
Yeah.
But do you have anything else to add with regard to funds flow or previous support?
Yeah, a lot to add to that, and this is an argument that I think we hear quite a bit. So, healthcare systems subsidize primary care. That's true here. That's true nationally. That will be true for as long as the primary care reimbursement model is the way it is.
Right.
And national benchmarks are still built in for what we use from a primary care compensation benchmark, what we expect from a productivity standpoint, and those expectations aligned with market norms. Because we know that professional collections do not offset the expense of primary care, there is always going to be that subsidy, or in a structural support model,
Right.
it's going to generate funds flow to ensure that there is sustainability. I think there's two things that are really critical in this conversation because there's an insatiable appetite to grow primary care. And if you think about recruitment and locations, we could continue to build a network and build a network.
Right.
The problem becomes specialty network adequacy
Right.
and capacity. What we don't want to do is build so much capacity in primary care that a wait for a specialist becomes 6 months or 9 months.
So in other words, there's nowhere for those referrals to go
Correct.
because we already have long waiting lists in our specialty care.
That's right. So it's really important that we balance the network out. We
Right.
need to make sure that there's access to specialty care because what we don't want to do is create a demand that's so high that we can't meet, that we disappoint our patients.
Right.
And then they vote with their feet. They
Right.
choose somewhere else to go to. I think the second point that's really critical in this is that primary care is absolutely the foundation for what we do in healthcare. That's pre-admission, that's post-admission, it's the lifespan of the patient. It's really looking across that continuum. What's really important to note, and I say this to everyone that says, well, we don't make money, so why do we continue to do the service? Should we just stop doing primary care? Well, the answer is no.
Right, of course not.
We just stop doing endocrinology?
Right.
No.
No, we have to provide all those services
That's
for our
right.
patients.
And if you look across the portfolio of the hospital, it truly is a Pareto rule that 20% of the services probably generate 80% of the revenue. There are many services that run at a loss, but it's critical that we have them at a foundation, particularly at an academic medical center. So if we just looked at only things that were quote unquote profitable or generated a margin for the hospital to reinvest, we'd be closing a lot of services.
Right.
And patients wouldn't choose us because you wouldn't receive comprehensive care here.
Yeah. I mean, I think that, it's fair to say that funds flow through the benchmarks does provide some expectations and there's accountability, but funds flow does provide additional support above and beyond what we've done before through the affiliation agreements for primary care.
That's right.
So we got another question, another one that I thought was interesting, and it's how does aiming for top 10 and 10 align with compensation at the 30th percentile? Now, of course, it's hard for me to address that question because it seems to be very specific, but I wanted us to focus a little bit on how we do differentiate our services at a national level and how funds flow may play a role in that. I want to emphasize again, though, that funds flow, again, does not equal compensation. It might support compensation, but it doesn't dictate compensation. So let's assume that this particular individual is working at the 30th percentile, at least for their clinical work. Then 30th percentile compensation might actually be reasonable. In fact, it might be higher because that's at parity than it would be with this academic gap at other institutions. Mm-hmm. However, if this person is working at the 60th percentile, then funds flow will actually provide sufficient funds to the department, inclusive of collections, to actually pay that person at the 60th percentile, and that's that concept of parity. Again, the chairs, their leadership decide compensation, so there may be a reason for compensation to not be exactly at parity because there are different missions that the departments might want to support and prioritize. But talk a little bit about that gap concept and how that might play in.
Yeah, the real impetus behind getting to a more than fair model and having something that's parity is so that we can reward people for the work that they're doing.
Right.
Full stop, that's the easiest way to explain it. It helps us because it, again, creates the reduction of uncertainty around what am I going to get paid, how is this going to work. If there's sufficient funds flow there to be able to compensate you at that level, then I think the question for you and I, as we're working with departments and as we're digging into the models and understanding how this changes things, is, well, why aren't you?
Right.
And
yeah,
that's
fair question.
The thrust of the work on the school side is
Yep.
around compensation, to say,
Yep.
how do we create more consistent, equitable compensation plans so that individuals don't feel that I'm getting underpaid or I'm undervalued for the work that I'm doing.
Right.
It starts with funds flow, because if there is parity there and it's generating the dollars to be able to support that level of parity and equity, then I think we have to start to address those gaps where we're seeing two things, and this is what happens in a funds flow model. You could be overproductive and underpaid.
Right.
You could be overpaid and underproductive.
Right.
And in a funds flow model that's predictive, those swings start to show up in the data, and they start to manifest in conversations we need to have to say, well, why is your compensation plan the way it is? If you have the dollars to be able to support and reward those high performers, we want you to be a high performer to feel fulfilled.
Right.
And there's also the piece of flexibility around work too, right? We don't expect everyone to produce at the 90th percentile. We need educators, we need researchers. We know individuals have different work-life situations, and we want to have the flexibility for individuals to be paid equitably for the work that they do.
Yeah.
And I think this creates a lot of mechanisms that we didn't have before to help open those doors.
Yeah, I mean, I think equity is a key concept, right? I mean, my sense would be that the person who asked this question about the 30th percentile feels undervalued, and we don't want our faculty to feel undervalued. But what we do need to do is hold faculty accountable. And so what we will be able to do now is see where those inequitable distributions or inequitable compensations occur and correct them.
Sure.
And there'll be money there for that through funds flow, because it may be that there wasn't before.
That's right.
And now that'll be supported. So another question, I think this is a key one that was submitted, was about compensation for advanced practice providers and how funds flow might assist in the rising cost of homes or living really in Denver.
Yeah.
And I've certainly experienced that having just moved here. So I think this is a great question, and APP compensation is an issue that we really need to address head on. I believe, and I'm sure you do too, actually, that we need to find ways to incentivize APPs for extraordinary clinical work that they do, but also reward them for work they do across all of our missions as well. The problem is that in our current model, I think we would both agree on this, there's incredibly high variability that seems irrational across our system in paying for APPs. And if there's so much variability and it's unpredictable and irrational, then it's really impossible to, assess equity, to retain those clinicians, and to reward them for the extraordinary work that they might do in the clinical and other missions. So that's something that I think is really important. Have you thought about this at all?
Yeah, we've, I think, spent a lot of time thinking about this. I agree that there's high variation in advanced practice compensation plans today. And the unfortunate problem it's created is there's a lot of internal jumping around when I can see that maybe I can go make $5,000 additional here because there is an incentive plan that rewards me in this department. The work sometimes is ill-defined, and how our advanced practice providers are used for the skills and talents that they have. Sometimes in certain situations feels like it's a great use of their skills, and others, they become glorified scribes.
Right.
That's not, from a fulfillment perspective.
It's not fulfilling.
That's not what I'd want to do if I were an advanced practice provider. So I think the key pieces are using the structural coverage components. We want to have something that's benchmark driven. Frank Ballinger, who's our Senior Director of Compensation at UC Health, has been instrumental in helping create that scale, delivering that across the school. Tatiana Emanuel, in her role as our Director for Advanced Practice, that's jointly funded between the hospital and the school, is working on this. And I think you and I and others across the campus really do need to tackle this and say, let's get to some consistency, because internal turnover is tough.
Right.
If you have somebody that's been super specialized and trained, and they've been with you for 10 years and all of a sudden they leave, you're creating a huge knowledge gap in that department or that division, and we need mechanisms to retain, sustain, but also recruit that talent, and that's something that I think we need to align to work on.
Yeah, I mean, I think that the goal for me would be to do the same sort of thing, make sure that APPs are rewarded in a way that's more than fair and rewarded across their missions, but have that be consistent.
Yeah.
So again, it's predictable, right? There's another question that came up, and it might be more appropriate for you, but we received a question about C-suite salaries. So I don't have a C, I have a D in front of my name, but or in front of my title. But I can start because the question was really, can we speak to how individuals at the executive level are paid? From my perspective, I'm happy to be completely transparent about that. My compensation was negotiated with the university, but it was also limited by fair market value.
Sure.
In other words, in not-for-profits, there are limits, or bands, maybe is a better way to say it, of how compensation can be used. And that's to prevent sort of, odd incentives or conflicts of interest. So for me, again, was negotiated with the university and then limited within a band of fair market value for the job that I'm doing. How does it work at UC Health?
Yeah, no different.
Okay.
It's benchmark driven, and we use Sullivan Cotter for a lot of our executive compensation. There is an executive compensation committee at the system level.
Meaning that a bunch of people who are impartial have to look at it.
Yeah, governed by the board.
And see if that fair market value band, but really that band is a benchmark, and see if that benchmark's appropriate in dictating your salary.
Yeah, it's really an interesting phenomenon because we don't have predictability we've not had predictability in our funds flow model. The number of times I hear comparisons of, well, my friend John makes this, and we're doing the same work. We get really personal about compensation here, which is of course interesting phenomenon because that compensation is personal. Right. It's what you've been able to do from a scope perspective, what will you do from a career progression, rank and promotion, right? All those things matter. It's no different from a healthcare executive perspective. We scope based on size of facility, based on revenue. We're comparing against like organizations, but the bottom line is we're using external benchmarks. So As much as I would, like to make up my salary and say I think I'm worth this, and he would do the same, we're bound by the same considerations that we need to use for our faculty. We have to use benchmarks.
So just like, someone's salary might be set because they're an orthopedic surgeon, that changes the benchmark. The size of your facility may change the benchmark.
Correct.
But there's still a benchmark there. And then others, your compensation committee or interdepartment chair says, well, within that band, what's fair pay for this work?
That's right.
So it seems like it works exactly the same.
Yep.
Great. So another question came in from Dr. Eduardo Davila, who's a professor of medicine and oncology, about the ongoing federal shutdown, which I guess is ended now, fortunately, but more specifically maybe recent changes at the NIH, and is asking how the School of Medicine is going to support faculty and researchers who are facing delays in grant reviews, funding gaps, and unfortunately quite a bit of uncertainty around their awards. So first of all, Eduardo, thanks for that question, for that question. And we are actually prepared. I thought about this ahead of time and actually talked about it a little bit at the state of the campus. So first of all, earlier this year, our department chairs, I think very generously, elected to contribute more than $12 million in bridge funding to those researchers who were facing delays and facing funding gaps. I should note that the School of Medicine also put $5 million away to support graduate students. However, I will note that through the hard work of people like Amy Gannon and Terry Carruthers and others, and in the grit, frankly, and the diligence of our faculty, that our NIH funding is actually up this year. Mm-hmm. Let me repeat that. Our NIH funding is actually up. So, well, some of the factors you mentioned, or Eduardo mentioned, really did result in a decrease in our grants throughout the last year of about 15%. So far this year, we're up over 40%. So it's really an astounding recovery. And I'll admit that some of that is timing, but if we were down 15 and now we're up 40, I think that reflects the diligence of our administrators in collecting those funds. But it also speaks really to the hard work of our researchers. And I would encourage them to continue to submit grants. And I would, tell them that we are here to support them, as I'm sure you are, as we go through these difficult times.
Yeah, the collective mission is critical. If one is harmed, we are not an academic medical center. And I think that is a uniqueness that we have as the only academic medical center in a 500-mile radius.
Yeah.
We have a duty because of that geography that we are training. We have more training programs than most large other AMCs because of that. We're training for the region. We are a regional resource, and we're a national resource.
We have to be.
So if we're harmed in that space, we have to band together and figure out how we protect that at all costs.
Yeah, I just want to emphasize for our researchers that and I think we together, and our chairs certainly do, understand the stress, the morale hit that this has caused them. But I would encourage them to continue. Things are looking brighter. The NIH budget was flat. We've heard rumors the NIH budget will actually get increased. So I think things are starting to turn on and turn back around. So try to keep your spirits up and try to keep the spirits up of those around you.
Yeah, when we talk about top 10 and 10, it's going to create a need for excellence in all these areas.
Right.
And if we fall short in any of these areas, we're not going to achieve that goal. I think the other thing that's important from the vision perspective as we're aligning is that this campus and where we've been over the past decades is going to fundamentally look different 10 years from now.
Yep.
And as we think about who we are, as the health system's expanded, as CU has grown, as we've worked together to build beyond just the Anschutz Medical Campus, we really have an imperative to make sure that this campus is sustainable.
Right.
And as we've talked about the external threats with HR 1, with changes to Medicare and Medicaid, we're seeing these things happen every day. Pharmaceutical companies want to take back discounts that have been provided to us for well over 30, 35 years. And those are the things that have actually enabled us to do what we've done. And it's put us on the forefront of academic medicine across the globe.
Right.
All those things could be at risk if we don't stay aligned and we're not lockstep together, protecting what's core to it.
Which is one of the reasons why we're doing these things, right? We're certainly facing threats, but I would say by all accounts, we're still doing great.
Yep.
And I think that's really positive. Anything else you'd want to leave the audience with before we close today?
I just want to thank you for the partnership. I think we've had a lot of fun, and it's not all butterflies and rainbows that it appears to be here today. I think how we disagree and how we're able to talk through conversations
Right.
and get to a solution is what matters most.
Great.
And I think you as a partner and your team and us working together just demonstrates that when you align and you reduce friction and you have a clear vision, you're pretty limitless in what
Right.
you can accomplish.
Right. I mean, our goal with Funds Flow isn't to make the work for our faculty harder. It's really to make a system that's more stable, that's more than fair, and that's sustainable over time, and to reduce the friction of our partnership, which I think has been very positive. I believe that the principles are sound, the details do continue to evolve, but we're listening. We're listening to each other, we're listening to the departments, we're listening to different specialists, and really trying to answer their questions as we move forward. I want to thank all of you for your engagement today in the audience and for the honest questions that you've put forward. I look forward to all of you joining my upcoming State of the School address in January. So watch for information on that and upcoming town hall in the spring that will feature our leaders in research. So please scan the QR code on the screen to fill out a feedback survey. As you saw from this event today, we're trying to address those questions and give you the information that you want. And finally, a recording of this session will be available on the Dean's Office website for anyone who might have missed it or wishes to revisit our discussion or ask additional questions. I'll also share the link in my next Dean's message. Thank you, Tom, for being here today, and thank to all of you online for joining us this morning. And have a great day and a great rest of your week.